Hello, ladies and gentlemen, and thank you so much for having me for this new episode of Brain Talk. And this time we'll talk about etiologies and MRI findings of, cerebral epilepsy. So, in many people with epilepsy, sometimes anti-epileptic drugs therapy will fail to control seizure, and we use, a specialized MRI protocol for, detect 80% of what's called epileptogenic changes on the brain. So remove these lesions can lead to seizure free for many patients. The medial temporal sclerosis, or called sometimes mesotemporal sclerosis, and cortical focal cortical dysplasia, are the most common causes of the seizure in the adults and also in children. Most common site of refractory epilepsy, firstly 60% for temporal lobe and 20% for frontal lobe, and parietal lobe for 10%, periventricular will be 5%, and lastly the occipital lobe. So 4% of people will have at least one seizure in the lifetime. Patient with first attack with seizure may be caused by any reasons like fever, medication, dehydration, lack of sleep. So in those patients, the brain has no any abnormalities. Whereas the epilepsy is used as is a definition used for if there is repeated and provoked seizures. So 60% of people with epilepsy can controlled by anti-epileptic drugs. So as we see here, this is the first seizure ever in the patient. Will have like 4% of the population. 1% of this population will have epilepsy. 0.4% of the population will have uncontrolled epilepsy, and these 0.4% will have 80% and epileptogenic focus or lesions here on MRI. So most people with uncontrolled epilepsy have like complex partial or focal seizure. The focal seizure refers to a seizure that affects only part of the brain, usually starting in the temporal lobe, after that spreading to whole hemispheres. So simple focal seizure, presents the person will remain awake for simple focal seizure. The patient maybe proceed or maybe reach or change for complex or generalized seizure. So complex focal seizure affecting a large part of the cerebral hemisphere. The person maybe lose conscious. If partial epilepsy spread from one hemisphere to other, they will lead to a second generalized seizure. The person will lose consciousness and have what's called tonic-clonic seizure. As we see here, this is the partial seizure will have a partial seizure divided or maybe divided to simple partial. Patient still conscious. In the simple partial, maybe patient will have aura. What's like patient start to have firstly before having seizure will have like abdomen pain. Sometimes some patients will hear something in their ears, or sometimes they smell a bad smell. That simple partial maybe change to complex partial. Patient will maybe lose here conscious. So complex partial secondary can change to a generalized seizure, which have a tonic-clonic seizure with unconsciousness. So we are now going to the common causes of epilepsy, or the etiologies of the epilepsy. We have 6 reasons or 6 causes of the intractable epilepsy. We have the MTS, what's called mediotemporal sclerosis, and we have a developmental in the brain, like FCD, what's called focal cortical dysplasia, heterotopia. polymicrogyria, and megaencephaly and schizoencephaly. And we have also epileptogenic tumors like ganglioma, DNET, pleomorphic xanthoastrocytoma, and hypothalamic hamartoma, and also gliosis like scars caused by infection or bleeding. And we have also another causes like Rasmussen encephalitis, cavernous hemangioma. And lastly, neurocutaneous syndrome. We have two syndromes. Firstly, Sturge-Weber syndrome, and we have also tuberous sclerosis. So this is a new or just a picture for the reasons. We have here polymicrogyria, focal cortical dysplasia, neurocutaneous syndromes like Sturge-Weber and tuberous sclerosis. As we have here some tubercles, and here some calcifications in this area, and we have also here a cavernous hemangioma and megalencephaly, a big hemisphere here, and also some tumors that can maybe cause the epilepsy, like ganglioma, DNET, pleomorphic xanthoastrocytoma. Lastly, and the most important one, is called mesotumoral sclerosis. So we have an MRI protocol for epilepsy patient. We have T1 and FLAIR and T2. Firstly, T1 we can appreciate, predominant in the cortical thickness, and there is also some interface or fuzzy. Sometimes the fuzzy or sometimes is difficult to appreciate the interface between gray and white matter. The gray matter, that occurs in abnormal location, such as heterotopic gray matter. On FLAIR, we have high signal in the cortex and subcortex, which can very, very subtle. Sometimes we have like pseudo-positive results, like anomalies, maybe should conferred by T2. On T2 and also SWI, we have must search for hemoglobin breakdown products, as we saw in the post-traumatic changes or in the tuberous sclerosis. Also, it's very helpful to see a calcification like in Sturge-Weber syndrome, in hemangioma, and also ganglioma. So, starting with epilepsy pathologies, we have firstly here a mesial or mesotumoral sclerosis. So, it's a special type of disease that hippocampus neurons lows and also gliosis and atrophy of the hippocampus. Etiology is a noun is associated with present febrile seizure in childhood. Another development which can be found in the mesotumoral sclerosis called FCD, which is called focal cortical dysplasia. Is 15% of the patients will find the FCD there. So MTS or mesotumoral sclerosis is the most common cause, of adult, partial complex epilepsy. Those, most common cause of surgery. Coronal T2 and FLAIR images, the most, sensitive to MTS. As you see here, this is, atrophied hippocampus with also enlargement of the temporal horn here, and lateral ventricle will have also high signal here, and the hippocampus, reflects for gliosis. So here is the MTS with cortical dysplasia. Here is MTS here, as we see here. This is a atrophied hippocampus, and here is the FCD. Or it's called focal cortical dysplasia, and this is a patient. This is here a patient, 35 years old, man with intractable temporal lobe epilepsy. The MRI shows slight intense in the left hippocampus, as we see here in axial blue arrows, and atrophied also in the hippocampus in the coronal images here, as we compared to the right one. The patient, this one was successfully treated with left, amygdala hippocampus, resection. This is after operation, resection of amygdala and also hippocampus to treat this epilepsy. So indication of hippocampus, identification of hippocampus, hyper signal on MRI. This is, hippocampus hyper intense with atrophy on T2 and FLAIR images in the appropriate clinical setting is an effective method for diagnosis MTS. The high signal volume loss may be seen in other diseases like epileptic state or status, and also low-grade glioma like astrocytoma, also DNAT. Also, we can see the high signal in the encephalitis. This is another case of epileptic state, the patient who have high signal of hippocampus, maybe due to the edema here, but when you see in the coronal image, you will see the same size of the hippocampus. So sometimes we'll find this hypertense, which indicates cytotoxic edema in the acute phase of the epilepsy. This is another maybe differential diagnosis. DNAT also can mimics MTS. The T2 was in a hyper intense, but the hippocampus is also enlarged here with some bubbles, as we see here. This is a typical DNAT. As we see this is with contrast. We see this tumor didn't take the didn't say any contrast in uptake. So here the second thing of our cause of the epilepsy is focal cortical dysplasia. We have here is this is a disease of congenital anomaly. MRI result very, very subtle sometimes and maybe even negative. The most common finding is cortical or subcortical hyperintense, especially on FLAIR. So we'll also see a fuzzy interface between gray matter and white matter, because this white matter looks like like a gray matter in that contains the neuron that did not reach the cortex. Here, another information is the of FCD is a malformation of cortical development, is the cause of 5 to 25% of focal epilepsy, most common cause of refractory extratemporal epilepsy, especially in children. So MRI finding here is the subtle cortical or subcortical high signal, often located at the bottom of deep sulcus, and also is fuzzy or blurred gray-white matter interface, focal focal cortical thickening, and also there is a transmental signs. Here another case. This is a T1 in the left, cortical thickening and blurring or fuzzy gray matter junction. The right here flyer shows a subcortical hyperintense, which indicate FCD in this patient. Here we have also a hypoplasia of the left temporal lobe, and with cortical thickening in this area here. So this is and also this white atrophy of the white matter, as we see here. His white matter atrophied. If you compare it with the right side, this is the same patient, as we see here. This is atrophied here, white matter, and also hyperplasia of the left temporal plasia, and with cortical thickening. This is another case. This is epilepsy in 15-year-old boy. As you know here, this is a superior frontal gyrus thickening here, as you compared with right side of the left superior frontal gyrus. Flyer shows hypertense or hyper signal in the subcortical white matter. These findings shows or indicate the typical focal cortical dysplasia. Transmental signs, high signal that extend from the subcortex to the ventricle system. It's like, you know, it's like a thin edge edge extends from the subcortical space to the ventricle system, as we see here in this very clear picture. This is a high signal here, extending from the subcortical to the ventrical system, which indicate FCD. The third reason for epilepsy is called cortical and glial scars. It's called, you know, allogeria, because, you know, this is by meningitis or, you know, birth injury to the brain. Cortical scarring due to the perinatal ischemia here usually affect, you know, the full-term babies. In infant, you know, the perfusion of the apex of the gyrus was greater than the cortex in the dip and in the sulcus, resulting, you know, what's called cortical shrinkage, which is more in the deep layer than the superficial layer. So the patient of the gyri is like mushroom shape, and this disease must be, you know, distinguished between or differentiate between gliosis and also was called polymicrogyria. Okay. This is you know, a patient 54 years old man who has, you know, a prenatal asphyxia when he was a child, and long history of refractory, you know, partial epilepsy. As we see here, this is a left, you know, scarring in the parietal side, in the parasagittal watershed, led to a cortical atrophy here. As we see, the gyrus like mushroom shape. That's indicate for, you know, scarring in this area. This is MRI here, shows also a cortical, you know, atrophied and cortical and subcortical tissue and gliosis here. This is atrophied cortex, based, you know, seen on T1 because of high signal resolution. The flyer here show also have a high signal that's indicate gliosis. The fourth reason for epilepsy, we see this cavernous hemangioma. It's a benign low flow vascular malformation with, you know, has tendency to bleed. 75% maybe like just only we see one lesion of hemangioma. 30% will have multiple hemangiomas, and it consists of compartments of different size of continuing blood product with from different, you know, evolutionary stages, you know, producing the appearance of what's called popcorn. A complete hemosiderin border will surround the lesion. So it's an enhanced CT only shows, you know, hyper dense nodules or calcification, but, you know, 50% of this, you know, patient will hidden on CT, best seen on MRI. So cavinoma with it's like in a popcorn ball with hemosiderin. T2 and SWI is most sensitive to find cavinoma. Also punctate hypointense foci like those on T2, and also we'll find what's called DVA, developmental venous anomaly in the cavinoma. CT will be negative in 50%. Calcification will find on 50% on CT. As we see here, this is a two hemangioma here. This is a popcorn-like, and also this hemosiderin rim. This is SWI sequences, which also can find small bleeding on the brain. This is developmental here venous anomalies that's drain directly into the right internal cerebral veins, and coronal also. T2, we can, you know, show the abnormal venous flow. This is a posterior central gyrus, you know, cavinoma on T2, T1, T2, and also SWI. We have must differential diagnosis of microhemorrhage. We'll see this is microhemorrhage on cavernous hemangioma. Also, we'll see on cerebral amyloid angiopathy. It's common in the patient with dementia, on patient with old age. Also, we'll see a microhemorrhage on hypertense microhemorrhage. Microbleed in hypertense patient will be younger than the age of CAA, cerebral amyloid angiopathy. Also, microhemorrhage will be seen on diffuse axonal injury, DAI. Traumatic hemorrhage we'll see on locations or specific location like corpus callosum, subcortical white matter, and the brainstem. Here, multifocal, subcortical black spots. This is black spots here, spot here. This is, seen in the elderly patient with, CAA. Here, another patient on CT it's a patient after post RTA. Here, this is a subarachnoid hemorrhage. We'll see also on the corpus callosum. We'll see on the white matter and also brainstem. We'll see sometimes this is small hemorrhage, microhemorrhage, which indicate diffuse axonal injury. We must, differential. Oh, this is a very important differential diagnosis. That's microbleed is very different from the CAA. The CAA is actually subcortical, but in the diffuse axonal injury is in subcortical. White matter in the white matter, and also corpus callosum and the brainstem. So we'll now move to brain tumors with epilepsy. This tumor, have the following features. They appear in the cortex, locate in the temporal lobe, mostly closely related to a developmental malformation, typical seen in the adults. Characterized by behavior, slow growth, well-defined tumors, free of edema, shows chronic symptoms like bone remodeling and scallop-like configuration of a chanced skull. Starting for firstly, ganglioma. Ganglioma is a cyst with enhanced mural needle. This is a typical, and sometimes maybe it's completely swallowed for ganglioma. A calcification maybe have 50% of patients will have calcification. Most common causes of this is the most common cause of neoplasm in temporal lobe epilepsy. Calcification, as we said here in the ganglioma, are common there and very important to differentiate from DNAT and also PXA, pleomorphic xanthosarcoma. As we see here, this is a picture of a ganglioma with calcification. As we see here, this is a cystic here, as we see in the T1 cystic, and when it have a contrast, we'll see a small ring enhancement without edema in the occipital side. This is another ganglioma. As we see here, very large cystic lesions will have a nodule which enhanced on T1 with contrast. This is a small one, cystic, no edema. This is nodule, enhanced. And this is another case also for ganglioma. This is cystic. Also here, small, maybe small edema, but there is no mass effect, and also enhanced nodule. Another tumor that may cause, the epilepsy is called dysembryoplastic neuroepithelial tumor. First of all, we'll see on MRI there is a swelling of the gyri. This is also bubble changes, like it's very small bubbles, intratumor, hyperintense. It's maybe like sometimes wedge shaped with keep pointing to the lateral ventricle. There is usually no or only small amount of enhancement. There is also, maybe we'll find a focal cortical dysplasia, FCD. DNAT is typically, vascular and inflating the affected gyri. As we see here in this picture, this will see bubulous appearance, swelling of the cortex, gyrus here. This also maybe it changes of the skull due to the slow growth of the lesion, which maybe change the bone to what's called scallop-like compression. There is another patient with have refractory partial epilepsy. Tumor is typical, viscular cystic aberrance with compression of the skull also. Third tumor is called pleomorphic axanthoastrocytoma. It's enhanced partial needle of the superior cyst. Adjunct to the surrounding meninges. Meningeal will be enhanced here. The edema will have the tumor will have edema here. Is different from ganglioma and DNT, that those tumors may have not edema, whereas PXA will have edema. This is very important in differential diagnosis. In the absence of meningeal involvement, pleomorphic axanthoastrocytoma is sometimes it's very difficult to differentiate from ganglioma. Here a coronal T2 and also axial T1 with contrast, which shows the characteristic of meningeal enhancement of the PXA. This is here the enhancement here, and this is another case of the PXA was very here difficult from to distinguish or to differentiate from the ganglioma, because there is no edema here. Here, number 4, we have a hypothalamic hamartoma. Hypothalamic hamartoma is gray matter mass without enhancement. It represents, a non-neoplastic congenital, heterotopia of gray matter in the hypothalamic tubercle scenario. Some symptoms is seizure, mostly is called gelastic seizure, and also sexual prematurity in the children. Here, this is a normal normal picture of the hypothalamus here. As we see here, this is the hamartoma in the hypothalamus area. We have also the another tumor. It's called tuberous sclerosis, Borvelli diseases. He is inherited diseases, cortical, we'll see cortical hamartoma calcified mostly in all patients. Also will have subependymal tubercle on MRI, and also those patients may have called subependymal giant cell astrocytoma. White matter will show abnormality. Typical clinical triad is called focal epilepsy. Patient will have suspicious adenoma and also mental retardation. Hamartoma is in many organs also, like including angiomyolipomas of the kidney, rhabdomyoma of the heart. This is here a patient with small tubercle in the wall of the ventricle system. Also, this is a white matter abnormality on those patients. Here, a multiple cortical and subependymal nodules calcified, as we see here on CT. Is cortical nodules here, and here also. Subependymal giant cell astrocytoma is a new feature of the tuberous sclerosis. These originates from the subependymal nodule near of the moral foramen, and maybe cause deadly hydrocephalus. It will take the contrast and will be marked enhancement. As you see here, this is a subependymal giant astrocytoma here, marked very clear enhancement, hydrocephalus, as you see here. This is another subependymal giant cell astrocytoma in tuberous sclerosis patient. Lastly, here we have like Sturge-Weber syndrome. It's a leptomeningeal enhancement on MRI. This will be cortical also calcification. Mainly in the posterior side will be a posterior area of the brain will have atrophied. It's a vascular malformation. Patient will have facial, capillary angioma like wine stain, and also will have choroidal and leptomeningeal angioma of the eyes. Angiomatosis with cortical calcium deposition and atrophy due to the venous occlusion and ischemia is the pathology of this disease. The clinical, symptoms is seizure, hemiplegia, aphasia, mental retardation, and also wine spots on the face. Here is, as we see here, this large cortical and subcortical calcification involving the left posterior half of the brain. And we'll see here atrophied posterior area of the brain with a with leptomeningeal enhancement and also thickening of these areas. This is a choroidal hemangioma seen in the Sturge-Weber syndrome in the eyes. Polymicrogyria is number 7 of causes of epilepsy, mostly seen on the Sylvian fissure. Also will have posterior atrophied, abnormal venous draining in multiple cerebellum gyrus. Is a malformation caused by changes in the cortical development in the late stage of neural migration. Multiple, polymicrogyria is formed in the deep cortex and in the normal stereo and grooves, which maybe disarranged here, as we see in this picture. This is a normal patient here, normal gyri here, but we see here a polymicrogyria in the grooves and of the brain in the deep. Heterotopia of the gray matter is a result of blocked migration of normal neurons along the radial path between the ventricle wall, ependymal, and the subcortical region. There are, 2 types of this gray matter heterotopia, what's called subependymal and subcortical. The most, common clinical presentation or scenario is intractable epilepsy. The gray matter heterotopia appeared as a nodular lesion with gray matter high signal in all sequences without any enhancement. As we see here, this is a hypertopia here in the lateral or subependymal space. This is here and also in this side. This is with high signal on T2, without any enhancement when you use contrast. This is another also heterotopia in the subcortex area. Schizencephaly is also a malformation or a fissure that's in the brain that connects the lateral ventricle to the subarachnoid space. The fissure is lined with gray matter. 2 types we have here, opening type and closed type. The patient will have seizure and hemiplegia. And also we have the most seen type is called the open type, which have the fissure extending from the ventricle to the subarachnoid space. This is a bilateral here fissure. We have here an open pattern of the right, and also we'll have here another closed pattern in the left side. This is also the same case here. This is we'll have closed one type of schizencephaly. Here is the open type of schizencephaly. By this, last slide, we finished the etiologies and the MRI finding of cerebral epilepsy. Thank you so much for listening.